And it's always such a privilege to be invited again and to ask to have input with an organization like Epilepsy SA. Because of the opportunity to explore things that we don't tend to explore in the clinical setting, because we are so, as doctors, so clinical about the disease. And I think that's possibly one of our faults, or one of our areas that we could work on, especially with neurological diseases. People often ask me, why did you choose neurology, you know? And I often say to them, I fell in love with neurology in my 4th year, and I was just, it blew my mind what the brain could do, but what could happen if it doesn't do it the way it ought to. You know, it was just like this amazing field that it's such a young speciality, relatively unexplored. There's still lots to learn, even for us who are the specialists in the field. You know, first thing, we need to just quantify the disease. It's estimated that 50 million people have epilepsy worldwide. And in South Africa, it's about 1% of our population that has, and I think that's grossly underrepresented. You know, I think it's way more than that. Because of the nature of the disease. So because epilepsy can be so dramatic, but then can also be so subtle, but can be so bizarre, that there's a range where people get undiagnosed, where it's subtle or it presents with bizarre symptoms. So people can be misdiagnosed as having schizophrenia or psychiatric conditions if they have things like temporal lobe epilepsy. So we are all used to have epilepsy being brain mal seizures. So you lose consciousness, you lose, you know, you have convulsions, or you have stiffening of the body, and you know, sphincters can be, incontinence can be there, and that's the sort of classic type, seizure type that we are used to. But you know, I cannot overemphasize how widely it can present. Speaking of temporal lobe epilepsy, that's the lobe of the brain where our emotions are, where our memory is, where our premonitions and functions, you know, things that you can't quantify, where your personality is, you know. And given that epilepsy, if you think of the brain as a mesh of electrical wires, and if you have 2 wires that are exposed and they just meet, and then you get this explosive reaction, depending on the part of the brain that is affected, you can get a wide range of presentations. So what we are used to is the loss of consciousness, the stiffening and the convulsions. That is when the whole brain is involved, both sides. So I usually make an analogy in keeping with electricity, because when the other specialties tease us, when they don't call us glorified electricians or the nerds of the profession, you know, that like we're just like the electricians must come and sort the electricity out. But in keeping with that analogy, I always say, you know, with your house, you have your municipal box outside the house, you have your main switch in the house, and then you have piping that leads to each room. So if your municipal box is out or your main switch is out, nothing's working. So that is a generalized seizure. That's when you lose consciousness, you have convulsions, or you have stiffening of the body, you know. But those areas in the brain are represented as what we call the brain stem. You know, people like to make jokes about medulla oblongata. So that's part of the brain stem. So that is the part that is your municipal box. That is the part that controls consciousness. That is the part that tells you to breathe without knowing it, that tells you how to beat. So that is where all these vegetative important functions happen. And it connects to something inside the brain called the thalamus. So that's your main switch. That is getting your electricity from your municipal box into the house. So if anything affects those two areas, then it switches off everything. Then the whole brain's affected, and that's why you lose consciousness, have convulsions. So all faculties are affected at the same time. So sometimes the fault starts with a short fuse in one of the rooms. Now that's an aura. So people have different auras. So because there's this short fuse, you have this, everything's working, but this light keeps on doing what it's doing, or this plug keeps on doing what it's doing. So auras present differently for different people. For people with temporal lobe epilepsy, often say a smell that some other people can't smell, or it's a feeling that's undescribable, or they know when this arm starts feeling a certain way, then you know that it's coming. So those are people fortunate, in inverted commas, fortunate enough to get the warning that the seizure is coming. Some people don't. So that warning may be in any room of the house. So if it's coming from the kitchen, something's burning. If it's, you get the picture. So if a seizure starts in your motor center, then without having affected consciousness yet, people have like this movement that you're not controlling, and then it stops on its own, so your consciousness is there, but the motor part is affected. So your short fuse is in one of the rooms. If it's a sensory center, people often have this, describe like insects crawling on one side, or an odd temperature on the other, on one odd feeling. That's your sense. That is a sensory seizure, Then you have the vision center, which is at the back. So the vision center ordinarily there's the vision center and then what we call the visual association center, right next to each other. So visual center says to us, oh, I'm seeing something in front of me. Visual association center, without us thinking of the thing, it's a wall, don't walk into it, it's hard, it's going to hurt you. All that it puts what you're seeing in context. But when you have that seizure, it can be cut off for a bit, So you can see something, your consciousness is there, but you are aware that is meant to be a door handle, but it looks like a pencil with freaky things sticking on it, So it's almost like jumbled things up during a seizure where the context is taken away, and then you're seeing things in odd areas that, ought not to be there. And then we get what we call, when it affects the speech area, what we call speech arrest. So that's when, because all faculties are fine, you want to say a word. So I want to say cup, and I know what I want to say, but it's not coming. So I'll say, the thing we drink with, that we put water in, that we, because at that expression center, there's an arrest for that particular word, or sometimes a complete arrest where, we take a while, there's a time lag, that processing, is delayed. And I'll say minor seizures in inverted commas, because people consider them minor because you don't lose consciousness, they're not dramatic, but they are seizures. So I often ask for a seizure diary with my patients. And, I have a friend in tech who offered to work on one where it's a cloud-based one, where I could, look at it from wherever, because I ask people to say, if you feel weird, just tick, like, it doesn't, the description doesn't, you don't have to have a description. And you'll find that you see someone after a month and they have two ticks. Like, oh, okay, we have two seizures, okay. And then let's walk through the brain then. Did this happen? Did this happen? Oh, that happens every day, you know? So people don't quantify and recognize it as seizures. And when you do, then you give the opportunity for the treating physician to then adjust your medication there. Because then your control is not misrepresented as, oh, this is a well-controlled epilepsy, you know. Temporal lobe, it is, you know, I still read on it and it just fascinates me because it's where all the soft things happen, you know. So it's where things that make you feel what you feel, that processing happens there. That this just happened and this is how I'm feeling today. And close to it is the frontal lobe, the underneath part of the frontal lobe, which is for personality, for impulse control. So your diplomacy is there, where this is a situation you can say something, this is where you can't. But you also have your memory center there. So all seizures, most seizures, I won't say most, seizures by definition involve an element of amnesia. So I love seeing my patients with their family because there is an element of amnesia and people tend to make up for it because I'm so forgetful, I make lists or I do this and that and it may not be a true forgetfulness. It may be the amnesia that comes with several seizures that are what we call subclinical because they are not easily apparent, and that in itself may be sign of poor control of epilepsy. So what we call collateral history or information from people who live with you. It's really so important because you give your account of your past with him and the other person says no, but you know, during the conversation you sort of moved on and talked about something else and then you came into the conversation or disorientated for less than a minute and then you carried on and the person may not be aware of that part where they did. So their awareness is there's a conversation, you're in it, and at some point, it seems like there's some detail that was missed, that you missed, but everybody knows, like, you know, so people just carry on and make up for that. You know, another question I often ask people, and I say, have you become more inclusive? Have you distanced yourself from people? And I often get yes. Why is that? Because people at work tend to think, I have a bad attitude, or somebody said I did this, so because I'm being accused of things I didn't do or say, I keep to myself. Now, during a seizure emanating from the temporal lobe, it is possible to do things that are not in your character, and you miss it and forget it. And somebody says, but how could you hurt me like that? How could you say X, Y, Z? And you know that it's something you never do, you never say ordinarily. But because of a misfiring in that area which includes memory, personality, and feeling, then one tends to have these seizures and feel offended by the reports that you did this, you said that, and think that they would never do. But not be aware that they actually happened and they have amnesia of them happening. So what the person comes to you and says is, I have a memory, I have declining memory, But unless somebody else who's with them a lot is able to actually define the scenario around that memory. Another presentation is headaches. Seizures are followed by headaches. So if you have a seizure for a minute, and you don't know, and in that minute you carry on doing what you're doing, which is what we call automatism. So you may be typing, carry on typing. After 10 minutes, you notice at the point we're typing gibberish, but like the motor is going, everything is happening, nobody's picking up. but there was a seizure at that time. But what people then present with is, I have this headache that just won't stop, or this fatigue that's unaccounted for. So you had a relatively normal day, but you're as tired as if you ran the comrade, And so that in itself is something to look into because that's something that follows seizures. So people experience what follows the seizure and not the seizure itself because it might have been so brief. But there's also what we call, over and above an aura, there's what we call a premonitory phase that can be up to 48 hours, where you feel unwell. But you're not sick necessarily. You're just maybe a bit irritable. It's just, you're not feeling great. It's like something's not quite balanced. But that can be, this is when whatever process is happening is working up to the seizure. So if I could explain the actual mechanics of a seizure, I'd say, the brain is never silent. The brain is always working. So the brain is like a car that's idling. It's waiting to respond. It's waiting for an instruction. So the idling bit is the chemical energy of the membrane around brain cells. They have to keep that membrane ready to fire. And by doing so, they're passing sodium in, potassium out. There's a lot of chemical interaction that's happening. So at any point, the car is idling. But at the point when you put it in gear and say, reach out and do that, that's when that chemical energy becomes electrical energy and you reach out and do something, right? So with a seizure, you get inappropriate instructions of that electrical energy. So it's either heightened or inappropriate. So if you're sitting and you have not voluntarily reached out your arm and it shakes, so that's an inappropriate electrical conduction that has been created or heightened excitation of the motor area at that time. So that is why with epilepsy, every single part of the brain has its function, but when it happens excessively, then there is a seizure because there is that aberrant, it's like, instruction for those electrical energy to happen. And then one then has a seizure. So with the temporal lobe now, which is feelings and there's, the temporal lobe is that lobe where you walk into a room and like, I don't like, I have a bad feeling about this. So, those kind of things. But now when that's heightened, you feel very emotionally unstable now. Because you're going from this emotion to the next, or the forgetfulness, or the behavior that's not typical of what ordinarily one would do, or extreme, like then it's confusion and it's rage, aggression, things that are not typical of that person. There's also bizarre dreams. So now you have your memory area right there. And it's almost like the brain will go fetch from your memory area images. So people, and this is where as a Black neurologist, I like to come into this because this is where then culturally it has a lot of implications for Black people, because if someone dreams of their grandmother giving a certain instruction to do X, Y, and Z, that is a big deal now. So now if you have this child and which you have had, who has had that keeps on having these, Gogo came in a dream and said this and that, go open this drawer and you find this, and they go open the drawer and they find that. So I often say to people, I can explain it up until the dream. Why you actually found the key in the drawer that you were instructed at that part. That's where it's too spiritual for me. I'm not qualified to then explain why that was true. But the fact that one would say, okay, it's a gift. This is where you have a spiritual gift. I'm not qualified to measure or not if somebody has. But that overlap between, let me say, if one had to have a spiritual gift of sort, it would come from the temporal lobe. That's where it would be controlled from. But now, to then decide when there is a seizure, that's a really gray area where I find myself fortunate culturally to understand that the fact that that's a gray area. And be in a position for, because then I'll, routinely ask a person, oh, so what did Umthandaze say? You know, that's information that people won't offer. Umthandaze would be a prayer person who uses water candles, or would be a healer of sorts, But that's not something people volunteer to a doctor. And that's something you have to ask, because that will determine if your patient will be compliant on treatment. So the example I'm giving of a child who has these dreams, and the family, for your clinical reasons, then you go and diagnose epilepsy, treat it, the dreams stop, then the family is upset, then you've taken away the gift, Then the next time you see the family, the person has had a grand mal seizure because the epilepsy progressed. So there are so many conversations to have and decisions to make when those kind of things are happening, but it requires sensitivity. It requires understanding of everybody's context. So if I am the head of such a department at a bank and then I'm gunning for promotion, I have epilepsy and I need these seizures controlled. And I, as a neurologist, say, okay, let's take a 3-month increment in, in the sort of drug doses, because some drugs need that, like slow increment in the doses. So if I decide, okay, let's do that, Jason, madam, it's reading your cue to say, okay. So some drugs require that, and a person has a cycle meeting, board meeting, all of these things happening in that 3 months. That context is different. So now, the reason I chose brain health as a topic was then what we tend to do in closing is that we say, okay, take this tablet to go home. But people say, what can I do? What you can do is you have your minimum 7 hours sleep. Sleep deprivation is a potent trigger of seizures. During sleep, your body goes into factory mode, produces all the chemicals and enzymes you will need to actually function during the day. What you can do is have a cardio workout routine. Research shows minimum 30 minutes 3 times a week. What can be done as well is, I say to adults, do you have a hobby? And the reason I say this is, hobbies are very healthy sources of dopamine. So dopamine is a thing that says, there's too many stress hormones here going on. Okay, let me go get a smoke, let me grab a cheeseburger, let me grab, those are short-lived rewards. But when you have a hobby, you have a constant supply of dopamine. What you can do is have a good support system that gives you oxytocin, and people will love laughing on you. That interrupts stress hormones, stress chemicals that then ignite seizures. So there's just things that we ourselves can do other than just treatment, that where we can actually manage our walk with the disease. Thank you.